Dr. Brian Koffman, retired family doctor, CLL patient myself, and the Executive Vice President, Chief Medical Officer, and the co-founder of the nonprofit CLL Society. And I'm going to be presenting some important research from ASH 2021, the American Society of Hematology's annual meeting and exposition that was held in Atlanta, Georgia, and virtually online in December of 2021. And the paper that I'm going to talk about now is real-world prognostic biomarker testing, treatment patterns, and dosing among 462 patients with chronic lymphocytic leukemia, small lymphocytic lymphoma. And as we know, in the way of introduction, the treatment paradigm for CLL/SLL has evolved with the approval of novel agents. INFORM is the largest US-based prospective observational registry of patients receiving treatment for CLL/SLL in the era of these novel agents. Registries such as INFORM provide a unique opportunity to examine real-world CLL/SLL treatment practices and outcomes in routine clinical settings outside of the research and arbitrary setup that's involved in clinical trials. This analysis reports the baseline characteristic, prognostic marking testing, and treatment patterns in routine clinical practice for patients in the informCLL registry. So this trial enrolled eligible patients with CLL/SLL between October 2015 and June 2019 who were over 18 and had received some approved treatment for CLL within 45 days of enrollment. They obviously had to consent to be in the trial. Based on treatment received at enrollment, patients were classified into 5 groups. Ibrutinib as a single agent or combination, chemoimmunotherapy, chemotherapy, immunotherapy, and novel agents. So what were the results? 462 patients were enrolled. 855, or 58%, were previously untreated, and 607, 42%, had relapsed or refractory disease. That means the disease had come back or hadn't responded to their first therapy. Patients were mostly enrolled from community-based practices, about 93%. The median age was like what we'd expect in CLL, 71%, with approximately 1/3 being over 75%. As we'd expect, 64% were male. We looked at performance ratios, and that was encouraging. The way we measure performance is with a tool called ECOG, and that was 0 to 1. For 852 patients, with staging was performed. Most had more advanced disease. 51% had RIDE stage 3 or 4 disease. The median time from diagnosis to initial treatment on the study for previously untreated patients was 1.5 years, and 84.3 months for relapsed refractory patients. The median range of follow-up for previously untreated and relapsed refractory patients were between 14.9 months, between 0.03 and 46 months, and 0.03 or 44 months, respectively. Sadly, prognostic factors in testing was done infrequently. FISH testing was performed in a dismal 28% of patients, 416, with higher rates of testing in previously untreated, 33%, than in relapsed refractory, when maybe that's who needs it the most. TP53 mutations was only tested in 11%, or 162 patients. IGVHG mutation in 12% of patients. Of patients with prognostic biomarkers available, 24% had deletion 17p, 27% had TP53, and 70% had unmutated IGHV. So testing these is pretty darn important. Let's go through the distribution of treatments that patients had. The most common treatment was ibrutinib, 46% across all lines of therapy, with 87% of patients starting on the recommended dose of 420 milligrams daily. That's certainly encouraging. For patients continuing therapy, 75% did not require dose modification. At 12 months, a little over 3/4 of patients continued on ibrutinib treatment, and 68% were still on ibrutinib treatment at 24 months. Bendamustine and rituximab, BR, and fludarabine, cyclophosphamide, and rituximab, FCR, were the most common regimens among patients who had chemoimmunotherapy. 80 and 85% of patients receiving BR and FCR respectively received less than 6 cycles. So they weren't able to finish the usual recommended therapies. Only 6%, 82 patients, were treated with other novel agents as their index treatment, with venetoclax, single agent or combination, is the most common administered, used mostly in relapsed refractory, 56 of those 82, more common than in previously untreated patients, where only one patient was used. One patient where venetoclax was used. Treatment received with patients with higher risk factors was evaluated. Of patients with deletion 17p, 101 patients, 59% received ibrutinib, but a frightening 28% received chemoimmunotherapy, and 7% received immunotherapy, and 6% other novel agents. Of the patients with TP53, 43 patients, 2/3 received ibrutinib, but still 21% received chemoimmunotherapy, and hard to believe 5% received chemoimmunotherapy without even immunotherapy. Over time, the portion of patients with 17p deletion and or TP53 receiving chemoimmunotherapy decreased, as we would hope. However, sample sizes are small. Of patients with unmutated IGVH, there was 121. A little less than half received ibrutinib, but a scary 39% received chemoimmunotherapy or chemotherapy. So what can we conclude from this? Results from the informCLL registry provide an opportunity to assess real-world CLL treatment patterns in the novel agent era. Ibrutinib was the most common treatment received, and most patients who received ibrutinib were still on it after 2 years. But approximately 1/3 of patients received chemoimmunotherapy, with BR, bendamustine and rituximab, being the most common regimen. Despite guideline recommendations, prognostic biomarker testing was infrequent, especially for TP53 and IGHV mutation statuses. These results indicate a significant knowledge gap in terms of prognostic biomarker interpretations and the overall treatment selection for patients with high-risk disease. With continued follow-up, data from this population will allow us to evaluate if this gets better in the real world. Will CLL patients' care improve? Are treatment decisions being better understood, and how these drugs work being better managed in the community? We can only hope so as we go forward.